Hello and welcome to part two of this talk on headaches. We're going to move on now to talk about some red flags for headache assessment and a good way to remember some of those red flags, and then some specific causes of secondary headaches.
So I think a really important thing to be aware of initially with something as broad as headaches is the red flags, because these are the signs and symptoms that you'll find that would require much quicker management, and potentially are signs of an emergency. So the first one to be aware of is sudden thunderclap onset. So this means a sudden severe headache that's at maximum intensity at presentation, especially if it's found in the occipital region of the head. That could show subarachnoid hemorrhage, although not exclusively restricted to that pathology, but it should make you suspect that. Something like a sudden neurological deficit or seizures could make you think of a malignancy or space-occupying lesion, or a bleed as well. The combination of jaw claudication, pain and tenderness over the temporal region, and being over the age of 50 is a sign of giant cell arteritis. This is definitely something that's important to screen for if the patient fits this demographic. The combination of photophobia, neck stiffness, and fever are common in meningococcal disease and meningitis. The reason I've put petechial rash in brackets is because that's specific to meningococcal septicemia, which is classically non-blanching, which means when pressure is applied to it with the glass test, the rash does not fade away. Next, loss of consciousness or reduced consciousness is important to be aware of, either from a collateral history or from the patient's history, or if they come in with reduced consciousness, because it could point towards something like a head injury or a bleed as well. History of trauma is obviously important for the reasons I've said before. The symptoms of sudden red painful eye, obviously accompanied with headache, is important because it points to an ophthalmic emergency, which is closed angle glaucoma, which I won't speak about in this talk, but it's important to be aware of because it is an acute situation. It can be accompanied by nausea and vomiting as well, even abdominal pain, or a history of previous eye disease or family history of eye disease as well. Something useful to be aware of. And lastly, it's important to know about the suspected sort of space-occupying lesion or signs of suspected cancer. These being worsening headache over several weeks, headache that wakes you up from sleep. If you have a family history of certain cancers, certain more common sort of signs that point towards cancer, like weight loss or being of older age. If the headache is worsened by coughing or straining, leaning forward, or if papilloedema is found on examination, these all point to raised intracranial pressure, which could point to a space-occupying lesion as well.
A good sort of concise way of memorizing some of these red flags is with the acronym SNOOP, where firstly you're thinking about systemic symptoms like fever or weight loss. Then you're thinking of secondary risk factors like underlying disease such as HIV or systemic diseases or cancers. You're looking for neurological deficit and symptoms and signs. You're looking for the onset, where a sudden, abrupt, like I said, a maximum intensity thunderclap onset, for instance, is a huge red flag. Next, you're looking at those who are slightly older age, particularly for something like giant cell arteritis, where they'd experience a progressive headache, especially in those over 50 years old. And then lastly, you're thinking about those with previous headache history who have noticed the change in the pattern, or where their headache has not been relieved through any previous attempts at management.
Starting with medication overuse headache. So this is something that's quite well defined, well understood. It's a headache that you get from overusing certain headache medications such as simple analgesias like paracetamol and NSAIDs, and triptans or opioids as well. It's often a bit of a vicious cycle for certain patients because they'll get chronic headaches and then they'll use a lot of headache medication and analgesia, and then their headaches will worsen or change, and it'll be difficult to sort of understand why. And a good way to manage these patients is obviously do the assessment that I said initially. Once you've excluded any and all red flags and more serious causes, it's important to then discuss withdrawing that drug that's causing the headaches for at least 1 month, reassessing the patient after around 1 to 2 months, and then after reassessing the patient, the original headache that they had, the one that they were using the medication for, may even return. So then it's important to then discuss using different analgesia or using the same analgesia again, but at lower doses and certainly less frequently. So next, giant cell arteritis is a really important differential to assess for pretty early on in your assessment of the patient. This is a chronic large vessel vasculitis that is not fully understood, but it usually involves the carotid artery branches like the temporal artery and the ophthalmic artery. The most common demographic affected are those over 50 and Caucasian women. The clinical features to be aware of are, apart from systemic symptoms, are upper limb stiffness, aching and tenderness, especially in the morning. All of these come under the umbrella of polymyalgia rheumatica features, which is seen in a large percentage of giant cell arteritis patients. Polymyalgia rheumatica is something in itself that needs to be ruled out if you suspect giant cell arteritis in a patient. Scalp tenderness will be in the side of the head in the temporal region, might be reported as pain on brushing or combing your hair. Jaw claudication is pain on moving the jaw, for instance after eating. In terms of the visual disturbance you get, the patient will describe almost like a curtain covering one eye that's painless, and it can be permanent or partial, it can be unilateral or bilateral. So diagnosing giant cell arteritis is important to do fairly rapidly and acutely because it requires a rather quick referral to secondary care, either within 3 days or on the same day if the patient has any visual loss. What they'll do in secondary care is a temporal artery biopsy or an ultrasound. The reason you might favour an ultrasound over a biopsy is because this type of vasculitis has skip lesions, which means some areas you'd take a biopsy from may show as completely normal. In terms of managing these patients, they will need prednisolone, either a higher dose if they have visual symptoms of 60 to 100 milligrams, or a lower dose if they don't have visual symptoms of 40 to 60 milligrams, and then reduce this dose over the following 12 to 18 months. Obviously, any patient who's on long-term steroids will need PPI for gastric protection, and they'll need a steroid card which reminds the patient of the side effects of steroids, the dangers of abrupt cessation, and a warning to others about the patient's medical status if they happen to fall unconscious or ill. In terms of monitoring these patients, they'll need physical examinations, catch up with how they're doing, measurements of ESR for inflammation, full blood count, and checking their osteoporosis and fracture risk because they're on steroids. So next I'm going to talk about meningitis and meningococcal disease. And aside from this, another important differential to consider, which I'm not going to be talking about, is encephalitis, which is commonly caused by herpes simplex and often managed with acyclovir. It's important to keep this differential in mind when thinking about a meningitis or meningococcal disease diagnosis. So meningitis describes inflammation of the coverings of the brain and the meninges. This can be infective or non-infective in origin. If it's non-infective in origin, it could be due to something autoimmune, a malignancy or an injury. If it is infective in nature, it's spread by the droplets or secretions from the upper respiratory tract in the air, and often bacterial or viral. It can also be fungal. If it's bacterial, the causative organisms are often age dependent. So if you're under 3 months old, they may more commonly be due to group B streptococcus or listeria. If you're of infant age, it could be due to Neisseria meningitidis or strep or pneumonia. And those who are immunosuppressed as well, often more prone to listeria infection. The clinical features to be aware of are hearing loss, which sometimes is the first symptom experienced. It's also important to be aware of the classic triad of neck stiffness, fever, and photophobia. And in addition, inquire about any paralysis or seizures. And because meningitis can lead to sepsis and meningococcal septicemia, which is life-threatening, it's always important to check that the patient is stable initially as well. Some specific points for the diagnosis of meningitis or meningococcal disease include some tests you can do in primary care, such as the glass test, which is where you press a clear glass against the rash, and then if it doesn't disappear, you can call it a non-blanching rash. And especially if it's a petechial, then those two things together are fairly indicative of meningococcal septicemia. In terms of your neurological exam, you can look out for some specific signs of meningeal irritation, such as Koenig's sign or Bartitsky's sign. Koenig's sign being when the patient lays supine, flexes their hip, and then finds it too painful to extend their knee. Or Bartitsky's sign, which is when the patient is also supine and they flex their neck and then automatically flex their hip. In terms of the observations you take, this includes respiratory rate, oxygen saturation, and temperature to check for fever. In addition, you can check urine output and GCS as well, all of which are useful for risk stratifying the patient for sepsis and shock. Next, you want to take some baseline bloods for comparison when doing a lumbar puncture, for instance, in terms of taking a glucose, or if you're going to give medication, for instance, checking bleeding risk by doing a clot screen as well. Next, you want to do a blood culture to find the causative organisms as well. And lastly, check that there are no contraindications to lumbar puncture first, such as neurological signs, as in focal neurology, papilloedema, raised intracranial pressure, or a bulging of the fontanelle in the neonate. And if none of these are present, you can do a lumbar puncture, preferably before giving any antibiotics. In terms of the management of these patients, if you're in primary care and you suspect meningococcal disease, you should give intramuscular benzoyl penicillin. If this doesn't delay transfer to secondary care, once the patient is admitted as soon as possible, you can give empirical antibiotics, preferably after the lumbar puncture, and then IV dexamethasone to reduce inflammation. So here's a summary table of the different results you could get from a lumbar puncture and the different things you test for you all to see. The important things to test are obviously opening pressure, to inspect the fluid, check the white blood cell count and the predominant type of white blood cell. Check the glucose and compare that to serum glucose. So it's always important to take a serum glucose before you do the lumbar puncture. And lastly, checking the protein as well. So next, we're just going to run through the various intracranial bleeds that you can get. Just take a second to think about which type of intracranial bleed this CT head is showing. You can pause the video if you want, or just keep going. And in addition, to just spot the sort of extra feature that's beginning to appear on this scan as well. So this is showing an extradural hemorrhage. On CT, this is classically a biconvex or sort of lentiform shaped collection of blood. Hyperdense often means it's acute, so that means it's white on the scan. It doesn't cross the suture lines because it's extradural, and that extra feature there was midline shift, which is when the collection of blood, the growing collection of blood, starts to compress the brain tissue and push the ventricles to one side. So you've got your dura, arachnoid, and pia mater, which are the coverings of the brain. An extradural hemorrhage describes a bleed between the skull and the dura, classically due to the rupture of the middle meningeal artery. So that lies under the pterion, which is the area in your skull in which the temporal, parietal, frontal, and sphenoid bones all fuse together. So it's particularly vulnerable to trauma. So if you were to get trauma in this area, it can cause a fracture, and that can rupture the artery. A small percentage are caused by venous issues as well, like dural sinuses or middle meningeal vein rupture. Rarely as well, it can be due to arteriovenous malformations or bleeding disorders. So this type of headache is severe. You'll get an initial loss of consciousness or some sort of extreme fatigue or confusion. And then what will happen after that is you'll get a lucid interval for roughly 6 to 8 hours, but then that depends on how quick the hematoma is growing. As the intracranial pressure then rises, you may get signs like a fixed and dilated pupil because the third cranial nerve starts to get compressed. And as even more sort of herniation and swelling occurs, the patient may experience muscle weakness, upper motor neuron signs, and further loss of consciousness. And obviously this is extremely serious. It can be fatal for the patient. What's important in terms of diagnosis is always to do a full neurological and cranial nerve exam, refer to neurosurgery, do an ABCD assessment, and do the non-contrast CT head as shown in the previous slide. Management is surgical, needing a craniotomy to help decompress the skull. Most people have good outcomes with this, which are obviously better with earlier surgery. So next we've got two non-contrast CT heads here, both demonstrating the same type of hemorrhage. One is an acute version, one is a chronic version. Again, you can pause the video if you want to just see if you can work out which one it is, and within that which one's chronic and which one's acute. So this is a subdural hemorrhage. The left image showing an acute bleed, which is white on the scan, and the right image being dark on the scan, showing a chronic bleed or hypodense, both of which are often described as crescent-shaped, and because it's subdural, it does cross the suture lines. So a subdural hemorrhage, as I've said, is a collection of blood between the dural and arachnoid meningeal layers. It can be acute or it can be chronic. Acute being occurring for under 3 days, or chronic being occurring for over 21 days. Commonly it occurs in those who are more vulnerable to falls, such as those with dementia, delirium, alcohol intoxication, because a big cause here is rupture to bridging veins via trauma to the side of the head. Other rarer causes could be being on blood thinners, arteriovenous malformations, and very rarely malignancy as well. So the presentation of this does vary depending on the size of the hematoma. You can have very few symptoms or a severe coma. So often you will get a severe headache. The patient may get gradual cranial nerve signs, slowly worsening confusion, and the patient may develop raised intracranial signs, raised intracranial pressure signs over time, such as exacerbation of headache on coughing or straining. The diagnosis, as with the previous type of bleed, it's important to do a full neurological and cranial nerve exam, refer to neurosurgery, do a full ABCD assessment. The management here does depend on the size of the hematoma and the level of neurological deficit and the clinical status of the patient. It also depends on if the bleed is acute or chronic. It can be managed surgically or conservatively. So lastly, you can pause the video, you can see if you can work out what type of hemorrhage this one is. Again, this is an example of a non-contrast CT head. So this is showing a subarachnoid hemorrhage, usually affecting areas like both of the sylvian fissures, the medial longitudinal fissure and the subarachnoid cistern. So subarachnoid hemorrhage is a bleed in the subarachnoid space. What it does is it causes severe damage to the brain through hypoxia, raised intracranial pressure, and direct injury. It can be spontaneous or it can be due to trauma. For the purposes of this talk, I'm going to talk about the spontaneous subarachnoid hemorrhage causes. So it's more likely in those with hypertension or smokers or a family history, or autosomal dominant polycystic kidney disease, because you're more likely to get berry aneurysm formation. And what can happen is people with these risk factors, or even sadly people without those risk factors, can develop aneurysms that burst and cause this collection of blood. Now, in terms of clinical features, this headache will have its maximum intensity within seconds. There may be some meningeal irritation, which can cause neck stiffness, and they may experience a loss of consciousness due to raised intracranial pressure as well. The diagnosis, as with the others, is heavily relies on ABCD assessment and examination, doing a non-contrast CT as well. Now, once the CT head does confirm that there's no raised intracranial pressure, then what you can do is a lumbar puncture, which is done to look for xanthochromia, which is a blood-stained CSF, and this should be done from over 12 hours from onset of symptoms. And in terms of management of subarachnoid hemorrhage, it's surgical. What you do is either a neurosurgeon or an interventional neuroradiologist can perform either a clipping of the aneurysm or coiling of the aneurysm, and after that you give a calcium channel inhibitor called nimodipine, which targets the brain vasculature. So lastly, these are some of the rarer causes, but ones that are important to be aware of. Obviously, certain types of tumor, such as GBM or glioblastoma multiforme, meningiomas or pituitary tumors, which will have their own specific signs. Idiopathic intracranial hypertension is raised intracranial pressure, often seen in young overweight females. And lastly, it's important to be aware that if patients have hypertension, a blood pressure is over 180 over 120, could cause something called malignant hypertension, which is where you start to get more overt signs of organ damage, retinal bleeds, raised intracranial pressures. So just as a quick summary of everything we've said, if a patient comes in with a headache, you'll want to take a full history and examination, assessing for any trauma or red flags. If you found any of these red flags or acute symptoms, you want to consider some further investigations like CT head without contrast. Next, if you've ruled out those things, you want to screen for giant cell arteritis. If the patient does have suspected GCA, you want to refer to secondary care and give a dose of prednisolone as well. If you've ruled out those things, you want to see if the patient has a suspected space-occupying lesion or malignancy, for which you'll need the 2-week wait service. Then, because primary headaches are often less severe, you'll check for that after all of the above. And then, if there's no identifiable cause, consider diagnosis of idiopathic intracranial hypertension.
So this slide is just to show a more detailed summary which has been directly taken from the Strong Medicine YouTube channel, and I've attached the link at the end of this talk for that YouTube channel because it provides a very useful overview of today's topic, and it's got loads more differentials for headaches than the ones I've mentioned, so this table is really good to use for future recap.
Okay, so that's a fairly brief run through on headache assessment. And if you want to read further about this, there's some really good websites about assessing for headaches, useful summaries, and good resources for anatomy, such as Geeky Medics, Clinical Knowledge Summaries, or the Strong Medicine YouTube channel. And these are some of the websites I've used to make this talk. Thank you very much.